Thanks so much for joining us this Sunday morning. 1.5 treatments delayed or cancelled. I mean, presumably the majority of those operations and other forms of treatment were delayed. They will happen at some stage.
Yes, this is the problem. We don't actually know when they will happen. In fact, we had record waiting lists before the pandemic of 4.5 million people on waiting lists. Now, we've now got an additional 1.5 million from our analysis. And on top of that, about 2.5 million fewer patients were seen in outpatient clinics, and they also will have their treatment delayed. About 274,000 fewer cancer referrals. So the question really people will be asking, and a lot of patients who've been waiting anxiously and suffering whilst they're waiting, is when they will have their operation, when they will be seen for their treatment. And what we're calling for is openness and transparency around how the NHS will now prioritise and how it will arrange its capacity, what we need to do to ensure that patients are seen.
Just in terms of how we got to these figures, though, before we get on to how we cure the problem, how much of this was a function of patients actually electing to avoid treatment, perhaps fearful that if they went into hospital, there could be a contamination risk, or presumably the vast majority of this was more a redeployment of resources within the NHS away from elective operations towards dealing with COVID?
Yes, the overwhelming majority of these numbers will be because the NHS intentionally ceased most routine services in order to create capacity for COVID patients. And that's because we started off with a lack of intensive care beds, a lack of ventilators, a lack of facilities to cope with COVID. And so hospitals had to, put to a halt their normal services. So it was not possible for me as a GP to refer patients for most conditions unless it was, extremely urgent. So the NHS wasn't functioning in a normal way. So that would have been the greatest reason for this backlog, this huge backlog. Now, some patients, of course, were anxious, and this was at a time, especially during the peak, where we were seeing large numbers of patients dying every day and falling ill. But the vast majority of delay would have been due to the NHS just not functioning for about 3 months. Now the backlog needs to be dealt with. We need to be very clear about how we do so.
Yeah, as you say, clear and transparent in terms of how we work our way through that backlog. And I suppose the decision-making process that allows you to get there, because, I mean, we guess there's going to be a triaging process. If you've got somebody, for instance, who needs urgent referral for cancer treatment, that presumably is going to be a more urgent case than somebody who's got a problem with, say, a hip replacement, requiring a hip replacement, though, of course, in terms of quality of life, that's very important to them, but it's not potentially a matter of life or death.
Yes, and this is why it's so important that the government is open with the public. And as you rightly mention, of course, cancer treatment is vital because it's very time critical. But then let us not also forget that patients who've been waiting now for several months for a hip replacement may be suffering in not being able to carry out their normal functioning. They may not be able to move easily from one room to the other at home. And these are patients who are often, in the later stages of their lives, where every month and year that is lost with suffering is a very important part of their lives, and that delay is very painful. Just to give you an idea of the scale of wait, we have about 26,000 patients now who are waiting more than 12 months for treatment, for an operation, compared to about 1,000 about 12 months ago. And we have a standard in the NHS of a maximum 18 weeks wait to treatment. So that's the scale of waiting that is already going on. And of course, what you'll also find is that because the NHS hasn't been seeing patients routinely in clinics, we'll also have an additional backlog because a lot of those patients who would have gone, for example, for an appointment with an eye specialist or a orthopedic surgeon would have then been put on a waiting list. So they have not yet even got onto a waiting list.
So when it comes to that decision about prioritising, I mean, it's a clinical decision, and therefore you would imagine it's clinicians who will make it. So will it be GPs acting as gatekeepers, deciding or making a choice, say, between somebody requiring hip replacement and somebody requiring oncological treatment? Or is it somebody more within the NHS management structure who control the purse strings?
So what we're calling for is an objective, clearly understood national systematic approach, because what you don't want is postcode variation. The public should know how the NHS is going to go about addressing this backlog, how it will prioritise. People need to know when they are likely to be treated. Now, of course, you need to have a clinical input into that process. And it may well be this needs to be done by senior clinicians, not just GPs, but also hospital doctors. You need to have some professional clinical input into that decision-making process. But it needs to be done within a national framework that is fair and objective. And that is why the government does need to be involved in addressing this backlog in terms of the pure numbers, but also being clear about how the NHS will develop the capacity to address this backlog. And let us also not forget the real worry we all have around the continued presence of the coronavirus and the fact that there is a worry of a second peak or even local outbreaks, because if those happen, that will again create difficulties if NHS services are put on hold. Well, and so our aim at the moment must be to prevent a second spike, and why all the efforts to contain the virus must continue so that the NHS is not overwhelmed and can start to clear this backlog.
Chaand, Nagpaul, thanks for your time. Thanks a lot.